Good evening and welcome to the webinar on problem behaviors. I'm Saima Ijaz, joining you from Nanaimo, British Columbia, located on the traditional territory of Snuneymuxw First Nations. And Saad is moderating. You can send your questions to him anytime during the presentation. Problem behavior in children on the autism spectrum is a complex phenomenon. Complex as it is intense and seems to occur without an apparent reason. It's unnerving, disruptive, and exhausting for everyone involved. And there are two contradictory schools of thoughts when considering the management. In our last 9 webinars, I've discussed how we can proactively diminish and prevent the occurrence of problem behaviors by creating a safe and nurturing sensory setup for the child for improved connection and skill building. I'll provide a recap of that at the end. Let's look at the overview. We have severity of problem behaviors and its impact on children and their families, risk factors and setting events, management goals, ABA approach, including functional behavior analysis, consideration of drug therapy, presence of psychiatric comorbidities in the autistic population, SPELL framework, and the non-ABA approach for tackling problem behaviors. In the last few slides, I'll share my thoughts on the causation of problem behaviors and what we can do at that time. Term problem behavior refers to behavior that poses risks to self or others and is disruptive to functioning. Examples include self-injurious behavior like head banging, skin picking, self-biting, and head hitting. Aggression towards others like hitting, kicking, biting, scratching others. Pica, ingestion of non-nutritive substances, including hazardous stuff. Disruptive behavior like destroying property and throwing things. And elopement, running away from home or away from the caregiver with no sense of danger. While even a single episode of this behavior is quite unnerving, they are described as relatively mild or transient or highly severe, treatment-resistant, and chronic. The pattern of occurrence can be episodic or consistent, and it can range from few occurrences per week to hundreds of occurrences per day. These problem behaviors sometimes co-occur with irritability, generally defined as outbursts of anger, frustration, and distress. When these issues occur regularly, cause harm to the individual or others, restrict participation in activities appropriate for the child's development level, and necessitates a higher level of care like constant supervision, multiple people required to manage when an episode is occurring, then they are classified as severe. While it's estimated that about 50% of autistic individuals with intellectual disability experience some form of problem behaviors, it's in 5 to 10% of these individuals that these behaviors are characterized as severe. The presence of the behaviors can result in a diminished quality of life for the child and the family. Child can suffer from life-altering injuries from head banging, pica, and elopement. There's a state of anxiety and fear for the behavior recurrence, which limits access to community resources as it may require costly setups and measures to manage the resulting circumstances, including use of extra personnel for assistance, special rooms, and mechanical restraints. The negative impact of problem behavior on the family unit is significant as well. Daily routines are regularly disrupted, well-being of family members is compromised, feeling isolated and living in a war zone has been reported, and financial resources are strained as extra care of the child usually requires fewer work hours and more supervision by the parents. They have to seek out respite care, special diets, medical visits and care, crisis-related expenses. Ironically, families with a child who exhibits aggressive behavior also has difficult time accessing supports specific to the treatment of aggression and feel isolated from lack of understanding from friends, extended families, and the community. Child and the family also face stigma and discrimination throughout their life. Diagnosis of autism spectrum disorder, another psychiatric diagnosis, severe intellectual disability, and severe deficits in receptive and expressive communication are all correlated with the presence of problem behaviors and are considered risk factors for its emergence. Management goals are looked as a short-term and long-term. In the short-term goals, we try to get protective equipment that's specific for the type of problem behavior for keeping child safe during an episode, such as arm splints to prevent hitting movement, or use of helmet and wall padding in case of head banging, child safety locks on doors, and getting a service dog for the child who has an elopement risk. Sedatives are prescribed and used as needed in case of an episode. Long-term management includes setting event assessment and therapeutic interventions, which could be ABA or non-ABA based, and drug therapy as needed. Taking a detailed look at a person's environment and daily routine, we can identify some physiological, physical, and social events that increase the likelihood of a problem behavior occurrence. These events may not be timed just before the behavior, could have occurred earlier in the morning, yet influence the onset of a problem behavior in the afternoon and are called setting events. Some common examples are feeling unwell, having pain somewhere, experienced by the child, ongoing insomnia or dysregulated sleep that can result in tiredness, state of confusion and disorientation, overwhelming sensory load, lack of structure, absence of the familiar caregiver, or high social demands are all common precipitants. Then there are events that happen directly before the challenging behavior and are a predictor for the onset of an episode. These are sometimes referred to as fast triggers, like being told no when the child is already not feeling so good, a change in a routine, or a broken toy. Parents usually have a good insight for these. It's always important to rule out pain as the cause, especially as digestive issues causing gastric pain, ear infections, and toothaches are more common in children on the spectrum than the typical children. As every child presents differently, looking for signs and history of what's noticed by the parents as pulling on ears, redness, cough, cold symptoms, fever, pressing tummy, could be indicators. Sometimes looking at the state of distress child's in, parents often worry if he's having some sort of a medical emergency like appendicitis. And a lot of times parents rush their children to the emergency. The FLAC scale, which stands for face, legs, activity, cry, and consolability, is one of the most widely used pain observation scales by the doctors to look at the signs and behaviors which indicate distress. It is primarily designed for measuring post-operative pain in infants and children from 2 months to 7 years, and those who have difficulty communicating pain due to developmental and cognitive barriers. The total score of FLAC scale ranges from 0 to 12, with each category where each category is scored on a scale of 0 to 2. In the right most column that says 2, we see the signs as frequent to constant frown, clenched jaw, quivering chin, kicking or legs are drawn up, arched, rigid or jerking, crying steadily, screams or sobs, frequent complaints, difficult to console or comfort. ABA-based intervention consists of many components like basic skill assessment, working on the skill deficits, functional behavior assessment, which is a child-driven process aimed at determining the specific conditions under which problem behavior is more likely to occur, like the setting events and fast triggers we just covered. Then functional behavior analysis, where problem behaviors are explained as socially mediated or reinforced through the interactions and responses of the caregiver, which maintain or increase the occurrence of behaviors. According to this approach, some of the most common and widely observed socially mediated reinforcers for children with problem behaviors include obtaining attention from adults or peers, escaping from or avoiding unpleasant circumstances, like when demands are placed on them by the parent or teacher, and acquiring or gaining access to preferred items and activities. Parents and the involved staff are usually advised to ignore and discourage these behaviors. Then there is functional-based treatment or behavior treatment plan that has two components: holding off the social reinforcers that are maintaining the behavior and strengthening of an alternate appropriate behavior, like encouraging use of words or pecks for making a request, which is called functional communication. Medications are considered when there are severe problem behaviors causing injury to the child, if the child is not responding to the intervention, and if there are other conditions or psychiatric comorbidities which are maintaining and increasing the occurrence of the behaviors. Like it's given to control pain, for regulation, for sleep regulation, and if there's diagnosis of ADHD, anxiety, or a mood disorder. Atypical antipsychotics is given to treat irritability in autistic children experiencing self-harm due to headbanging, self-biting, and self-hitting. Benefits of the medication is carefully evaluated as it has considerable risks involved. Parents need to know that medication will not cure autism, that it does not help every child. It does has side effects, so some blood monitoring will have to be done. These drugs are costly, and the child may develop tolerance or dependency, meaning it might be effective for a while and then not anymore, or you will not be able to taper it off. Medication does carry some benefits. It can reduce irritability, improve challenging behaviors, child may sleep better and may function better. Incidence of psychiatric comorbidities in children on the spectrum is quite high. 78% of children with autism have at least one mental health diagnosis, where from age 3 to 5, incidence is 45%. For ages 12 to 17, it's almost doubles up to 86%. 50% of the children have one diagnosis, 25% have two, and another 25 have three diagnoses. Girls are 2 times more likely to have anxiety. Children with intellectual disability, 4 times more likely to have behavior or conduct problems. Most commonly diagnosed is the condition of behavior and conduct problem, followed by ADHD, anxiety disorder, OCD, mood disorder, and sleep disorder. Less common are schizophrenia and catatonia. 20 to 57% of autistic youth have been reported to have symptoms of social anxiety, incidence of the diagnosis and severity increases with age, while many with depression stay undiagnosed, which is also quite prevalent. Suicide is a leading cause of premature death in autistic youth, teen, and young adults. All in all, this data is quite scary to say the least. Years ago, my thought process was influenced by SPELL framework, which is widely used approach for supporting individuals with autism spectrum disorder. It was developed by the National Autistic Society in the UK and is now used in many countries around the world. SPELL stands for Structured Environment for Individuals with ASD. This can include things like clear routines, visual schedules, and consistent expectations. Positive, focusing on positive behavior, interests, and strengths rather than negative behavior and weaknesses. Empathy, importance of understanding and empathizing with the individual with autism. This can include things like active listening, trying to see things from their perspective, and being patient. Low arousal. This refers to the importance of creating a calm and low stress environment for individuals with autism spectrum disorder. This can include things like reducing sensory overload, avoiding sudden changes or surprises, and providing a quiet and comfortable space for the children. And links, this refers to the importance of creating links between different aspects of the individual's life. This can include things like connecting with family, friends, and community resources, as well as linking different aspects of the individual support network. By creating links, individuals on the spectrum can feel more connected and supported, which can lead to better outcomes. Now, coming to my thoughts and views. If we consider behavior as a way of communication, then we can try to understand why what the child is saying and why. If he's trying to gain attention, is it because he's not feeling connected? What's the reason behind the irritability? Is he in discomfort or feels that some of his basic needs are not being met? Where STEM behavior seems like coping mechanism, we might want to dig deeper to address whatever is making the child feel the need to cope with at this young age. Severe problem behaviors like elopement and aggression, in my opinion, are more like a cry for help when the child is having a panic attack. And spacing out or self-harm could be when the child is experiencing dissociation. Secure attachment, which is seen in less than half of the autistic children, is associated with improved connection, reduced behavior, and better learning. Both parental sensitivity and insight into their child's needs promote secure attachment. There are simple steps that can be made to make a considerable difference. Setting a routine with the child based on his sensory preferences, like use of sensory fidgets that he likes, rocking, music, cuddling for 15 to 20 minutes once or twice a day. Teach the child deep breathing by taking turns at blowing bubbles or feathers, or by modeling or use of, there are lots of slow breathing apps that you can set it up as, say, 15 breaths a minute and then gradually reduce it to 12. So get used to the child with the visual that they bring up on the screen. Set a 20-minute time delay on an active routine of running, jumping, rolling, or bouncing together. Along with taking steps for developing non-verbal communication alongside thoughtful use of verbal communication. It could be by using gestures, sign language, word and pictures, visual boards, personal vocabulary books, depending on child's learning strengths. A board like this can be used for word and picture recognition when the child is calm, and then for communication when he's sad, angry, or withdrawn. Once he gets upset, it's not going to work, but can be used when he has calmed down again. Show him how he might have felt. You can use it in combination with a choice board to help him figure out what he can do to feel better, like having juice, a gum, play music, sit on the rocking chair, have a snack, or taking a nap. Now let's look at the risk factors and the setting events for the problem behavior with a different perspective. The child has a diagnosis of autism spectrum disorder and has an intense sensory system disorder, which has two components. Sensory processing deficits, meaning that he can't make sense of what is being said and shown to him, so he's unable to comprehend, communicate, or learn in his current setup. He feels insecure and extremely dependent on his routines and the constant presence of his primary caregiver to keep it together on his best days. Severe sensory sensitivities to sound, light, smell, touch, which puts him in a constant state of discomfort, causing disturbed sleep and appetite. He might be feeling tired, nauseous, confused, and fearful, and he cannot share it with anybody. And then imagine the fast trigger that his toy that he was probably using as a sensory fidget just breaks down. So we can see here where the child would seem spaced out, inattentive, at one time could be in distress, hyperactive, or irritable as he needs and expects help to feel better. Or he could be totally overwhelmed and have a panic attack-like situation, which is fight, flight. With this understanding, we can find ourselves approaching the child with empathy and kindness. So problem behavior of an autistic child warrants an understanding and a kind approach while keeping ourselves safe. It's important to deal with the situation in a non-judgmental and calm manner. And remember that the child is scared out of his wits. He's overwhelmed, has no control over what he's doing. He might not be able to recall what he did later. So be with him, stay calm, keep verbal communication to the minimum. Approach from behind is always better. Give him PRN if you have, but in any case, apply deep pressure on his tense arch body with a weighted blanket and wrap your arms tightly around him. Hold him close and deep breathe with an audible sound. The breathing rhythm and the pressure will gradually slow down his breathing and heart rate. Like slow down to normal. Usually it's very accelerated at this point. As his body begins to relax and he leans into you, you just loosen your grip slightly and rock him. Or use his other favorite distractors like humming, music, sensory fidgets, or any calming apps. Continue to deep breathe and share a communication board. By the time child calms down, he would be exhausted and disoriented. To help him reconnect, use a simple visual board. See if the child would point or say something. Otherwise, point to pictures and words which seem to describe how he might be feeling or need to do to feel better. Or use another board for making a choice of an activity or a snack. Once the child is back to his usual routine or taking a nap, review the setting events or keep in mind what spell stands for and try to figure out what could have been missing to have caused this meltdown. For more able youth and teens, I did encourage them to make a list of what would make them feel better when they're feeling sad or frustrated and revise it often. Have a copy of this available at home, at school, and say grandma's place, or save it on his device with a reminder to check to make a choice when needed. Once feeling better, ask them to write down what make them feel sad or frustrated and share if they feel comfortable. Like you can encourage them to share with the family, with a friend, with an uncle, aunt, with a school counselor, with a therapist, but not to keep it to themselves. To be able to connect with others, self-regulate and share our feelings, express our needs, and ask for help is necessary for everyone, especially for children for feeling secure and emotionally well. I request the parents, along with professionals, that before looking into what social reinforcers are responsible for maintaining the problem behaviors, please work at figuring out the root cause of such huge stresses carried by these little children. They are so much more than their diagnosis of autism and behaviors. Think about what we can do to modify our way of interaction and their sensory environment to help them feel safe. While some supports for autistic children living with intense traits may always be needed, right and early intervention can help the child and his family enjoy a much better quality of life and a peace of mind both at home and in the community. I have covered how to focus on child's interest-based vocabulary in a book format for comprehension, along with how to initiate play, daily skills, basic language, and social skills in my previous webinars. Also, how we can use child-specific vocabulary and real-time scenarios to create social sequences and narratives for awareness and interest in reading, along with using keyword and picture association for better comprehension and attention for class lessons. Equally important for us is to accept and respect the needs of autistic children and individuals, help them accept themselves and feel proud of their efforts, and keep an eye on them as they are far more prone to cruel teasing and bullying than the typical children. Working on these steps, I stay hopeful for even the level 3 children on the spectrum for improved emotional well-being and their learning capacities. I hope that if we play our role well, next step for these children would be STEM education. STEM education is often defined as preparing students with knowledge, competencies, and socially relevant skills required for STEM disciplines such as system thinking and problem solving. The data from the National Longitudinal Transition Study 2, which is a national representative sample of students with an autism spectrum disorder diagnosis eligible for special education, shows that 34.3% learners with autism declared a major in STEM field in post-secondary education compared to 23.8% of students in the general population, with a considerable lead in the field of science and computer sciences. Of course, majority of these kids are like they belong to level 1 and some from level 2. With this positive note, I conclude tonight's presentation. Let's see if we have any questions.
Yeah, we have 5 questions today. Our first one is, what seems to be the reason behind higher incidence of anxiety diagnosis in the high-functioning autistic children as they grow into teens and adulthood?
It's autism-related stigma and internalized shame that causes many autistic individuals to try to camouflage or mask their autistic traits. They may copy regular folks' speech, dressing, body language, and facial expressions, as well as try to hide their reactions to overwhelming sensory stimuli to be accepted by others. It is, unfortunately, it's partly society's fault for placing this impossible expectations on the autistic individual to be like neurotypicals for their social inclusion.
Our next question is, are there different types of non-ABA consultants available in BC? And if so, why have I not heard about them?
You might have heard of RDI, which is Relationship Development Intervention, and also known as floor time. I know that there are at least a few RDI consultants in BC. I just shared with you about Spell, and then there is Teach and Apt that I work with. Reason you might not have heard about non-ABA consultants is because in BC, RASP list, which stands for Registered Autism Service Providers, carries the names of just the ABA consultants. And for now, parents can only use funds, ministry granted funds for ABA consultations and services. Next.
You seem to carry reservations and strong opinions against ABA therapy, which carries data for success and has evolved so much over the last 20 years. Why is that?
Yes, I do have personal reservations as my son did not make any language goals in a 2-year time period of their intervention. And there was a significant increase in the recurrence of his problem behaviors, which I was told to ignore. And I did for a while and then really felt bad about. However, now my views are more based on the data on the mental health issues for this population and the shares of autistic adults who received the therapy as children and benefited by gaining linguistic goals, along with the views of their family and some of independent researchers on various aspects. Like I'll give an example of a few. Notion that there is conditioning to discourage unconventional but harmless and important behaviors called STEMs to fit in the society. Theory that ABA might interfere with identity formation and depersonalization because of tension between conditioning and the individual's natural self, as quite a few folks mention phrases like, my fake self does this, but my true self feels this way. Another important one is that ABA therapy could make children more vulnerable to abuse and bullying because of the compliance conditioning that's done, which makes it harder for them to say no or leave a threatening space.
Our next question is, I heard that ACT is holding a live event about autism mental health and suicide awareness. Can you comment on the suicidal risks in autistic individuals?
Suicide is a leading cause of premature deaths in autistic youth, teens, and young adults. They are significantly more likely to think about an attempt than members of the general population. They suffer with a higher incidence of undiagnosed depression as they are less likely to admit to themselves and seek help. Also, most mental health professionals do not look at identifying depression and suicidal risks, like the warning signs, or intervene when autistic individuals are in a crisis. Some of the warning signs are if the person seems in obvious distress, shows sudden or increased withdrawal, there's marked increase in the rate or severity of self-harm, experienced, if the person has experienced a recent traumatic event, And if there's worsening in the level of symptoms of anxiety or depression, a person is showing hopelessness and is making statements like no reason for living or no sense or purpose in life. These shares are more with their peers than with the families. And so awareness of these issues is very important. The event that Autism Community Training is holding, I believe it's both in person, and there's some you can watch it online as well.
All right. Now our last question is, in your presentation, you mentioned disassociation, which I thought was linked with childhood abuse. Can you share more on that?
Not much research has been carried out on disassociation in the autistic children, but they are more likely to, they are definitely more likely to experience abuse. Dissociation has been observed in 18% of autistic youth with social anxiety, while many autistic adults have shared a set of dissociative experiences, including depersonalization and derealization. It's been described as any other dissociation that we've read about, like an automatic process where brain draws a wall between the person and the harm, like withdrawing from the outer shell of the body and retreating into the inside that is unaffected by the outside world. There are others who explain it as a period of completely spacing out with either no memory or feeling like they're walking through a space full of gel. While they are told later by their friends that they carried out most of their daily routine as usual, as much as crossing the road or taking the bus. It seems to me that there are lots of work cut out for all of us if we want to improve the current outcomes. And with this, I conclude my last webinar of the series. We've covered 12 aspects of autism spectrum disorder, where I've seen families and individuals struggle most. You can find the links for the webinars on the education page of autismsolutions.info. And if you have any questions, please reach me at saima@autismsolutions.info. Thanks for joining us. Stay well and good night from both of us from Vancouver Island.